Erin and I want to start with a really big, heartfelt first bite thank you. We have been so encouraged by your kind word, your messages, your glowing reviews of First Bite. This has been a labor of love for the last year and a half, and we are grateful for y'all being on the First Bite journey with us and supporting us because we work full time and this is a full-time gig on top of it. And we do it with joy because we understand that the world of early intervention pediatrics needs evidence in it. So we sweet talked the folks with speechtherapypd.com, and as a thank you giveaway, we have come up with a free pod course subscription. So once we hit 130 iTunes written reviews, we're going to pull another name out of the hat, probably with the assistance of an ever so handsome goose and a bear. And that person will get a free pod course subscription. So over 175 hours of continuing ed plus 19 new continuing hours each month. And there's a new episode every Monday, Tuesday, Wednesday, every other Thursday, and the short course, 9 series long, All Things Ethics with Elise. And that's our way of giving back. So thank you. So please keep the reviews coming. We only have a few more to go, but once we hit 130, then we will pull that name out of a hat. Happy 2020. Thank you for joining us on the journey. And seriously, y'all rock. Thank you. Hey, so by now, I'm hoping that you've heard about the brand new pod course subscription that Speech Therapy PD has rolled out. For $79 a month, you get over 175 hours of ASHA continuing education with 19 new episodes a month. That's fantastic. Well, they want to make sure that you also know we have a brand new coupon code. So the coupon code is F as in first, B as in bite, followed by the number 20, FB20. And that brand new coupon code will give you $20 off the pod course subscription. So you get 175 hours of continuing ed plus an average of 19 new hours a month, all for $59 a year. And we cover everything from early intervention to schools to adults to ethics. So be sure to type in F as in first, B as in bite, and then the number's 20. Enjoy your coupon, or as my kin folks say, enjoy that coupon. Hi folks, and welcome to First Bite, Fed, Fun, and Functional, a speech therapy podcast sponsored by SpeechTherapyPD.com. I am your host on this nerd venture, Michelle Dawson, MS, CCC, SLP, CLC, the All Things Peds SLP. I am a colleague in the trenches of home health early intervention right there with you. I run my own private practice, Heartwood Speech Therapy, here in Coletown, South Carolina, and I guest lecture nationwide on best practices for early intervention for the medically complex and fragile child. First Bite's mission is short and sweet, to bring light, hope, knowledge, and joy to the pediatric clinician, parent, or advocate.
By way of a nerdy conversation, so there's plenty of laughter too.
In this podcast, we cover everything from AAC to breastfeeding,
ethics on how to run a private practice,
pediatric dysphagia to clinical supervision,
and all other topics in the world of pediatric speech pathology. Our goal is to bring evidence-based practice straight to you by interviewing subject matter experts.
To break down the communication barriers so that we can access the knowledge of their fields.
Or, as a close friend says, to build the bridge.
By bringing other professionals and experts in our field together, we hope to spark advocacy, joy, and passion for continuing to grow and advance care for our little ones.
Every 4th episode, I join in. I'm Erin Forward, MSP, CCC-SLP, the Yankee by way of Rochester, New York transplant who actually inspired this journey. I bring a different perspective, that of a newish clinician with experience in early intervention, pediatric acute care, and nonprofit pediatric outpatient settings.
So sit back, relax, and watch out for all our squirrels and enjoy this geeky gig brought to you by SpeechTherapyPD.com. So today's episode falls in the fed, fun, and functional categories. And today's guest, I am personally in awe of and humbled by the joy that she has brought to our own little Pack Dawson family. Today, we have on the one and only Angela N. McLeod, PhD, CCC, SLP. And as I'm the mama, and I'm okay with saying this, and I did double check with her too, this is our sweet little Boo Bear's SLP. And y'all, this lady has helped us in so many ways with our Theodore, who before he met Dr. Angela, he called himself Deedador because he couldn't say Theodore. And his favorite thing to eat was Tootsies because he couldn't say cookies. And when he asked you to sit with him, because of that little lateral lisp, that sit with me did not sound like sit with me. And she even cleaned up his F for TR swap substitution so that when he asked for a fire truck, it didn't sound like a fire truck. So, haha, there's your last 4-letter word joke of the day. But between Dr. Angela and her yubby yadies, because Bear called all of the graduate student clinicians the lovely ladies, yubby yadies, and his amazing early interventionists, the Brants, and his God-sent ENT, Dr. Garner, who has done several surgeries, and we have one more to go. Between all that, Bear has made tremendous progress. And it's not lost on me that this has been a collaborative team effort, and it's been ongoing for 3.5 of his 5.5 years to get him where he is. And that journey as a mama bear has been hard and scary, and on a very deep level, incredibly frustrating to be an SLP and to not be able to help my own kid. And then Dr. Angela took me aside one day while I was observing a student clinician with Boo Bear, and it was through the closed loop TV. So we were watching her work with Bear, and she said, "Michelle, you have to be his mama and not his clinician." And it righted my world. It gave me permission to hang my clinical hat up and just let it go. It gave me permission to not drill, to celebrate, to not harp on each error pattern, but to gently cue and happy dance when he got it right. And y'all, there's so much more joy in our journey. Also, y'all, this amazing woman has managed to put up with me for all this time and overanalyzing him for several years. And she still likes me and still talks to me. So, what's up? Now, I'm not sure how I pulled that miracle off, but we did. And here we are. So earlier this year, as we were prepping for the Skisha convention, and I got to talking to her about it in passing, and then we got to talking more about it in depth at the convention, she made a comment about some myofascial coursework that she had just completed. And it piqued my curiosity because even though I'd had it on my professional radar, some of the folks that I know that had taken the coursework had unfortunately misconstrued it as basically oromotor exercises on crack. And we know that those are non-evidence based. And it's had me on the fence. Truly, I have had misgivings. But here's a woman I admire and love. And if she did it, and I have seen her skill set and her evidence-based work firsthand, then I needed to know more about it. So I managed to sweet talk her into coming on to clear the air about what it is and what it's not. And so, yay. So here we are. So Dr. Angela, woman, thank you for coming on. But first and foremost, thank you for everything you have done for my little Deedador. Because and I'm really hoping that he stays quiet for this hour because he was so excited that I was talking to you, but I withheld TV all day long, and they're presently watching Angry Birds 2, and I'm hoping that will be enough to keep him entertained. But hi.
Hi, Michelle, and I want to thank you so much for your gracious introduction as well as all the other comments. That was very kind of you. I'm just really at a loss for words as much talking as I do. after all of that. But
Well, it's like an occupational hazard. I mean, we SLPs are supposed to be great communicators, but when it comes to like the end of the day, we're all befuddled at the end. So like, and I gotta say, multisyllabic words are really hard for me on a good day. So I kind of think I might know where Bear gets it from, aside from all the hearing loss. So like, okay, but I'm serious. I have so many different questions. And what my biggest fear, because of what's been misconstrued to me, and Erin and I did the tethered oral tissue talk several weeks ago. And we talked about like what the evidence says about like what the purpose of tethered tissue is. Like we're supposed to have frenulums, and they do like anthropologically like serve a purpose. And then we looked at like some data that talks about like prevalency of um, um, overdone surgeries versus necessary surgeries and outcomes and blah blah. And so we did all of that. But honestly, I have been put on the fence because I have seen so many people that have said, well, as soon as you take this course, you'll understand that all the frenulums have to be cut. Everybody has a tongue tie, everybody has a lip tie, and they all have to be cut. And it was like flat out stated to me like that. And I'm like, that is wrong. And
yeah.
so like, that's the baggage that I bring with it. But I know that you're not that person.
Yeah.
So we have so much myth busting to do.
Oh, yeah. Well, I'll just say that I think with any type of information that is put out there for a large set of individuals, there are possibilities of individual interpretation because we all are clinical scientists. We're all independent clinicians and making our own assessments. I do think that there's opportunity for some information to be misinterpreted or acted upon inappropriately. But for the most part, when it comes to the frenectomy, we don't want to make any decisions based on visual dimensions only.
Oh, wait. So you mean those Facebook pictures when they post
Yeah.
on the Facebook pictures a static picture of a kid with their tongue up? We shouldn't all jump on and say, cut it, cut it, cut it.
Right. Yeah, because everyone's
Yeah.
anatomy is a little different. I could look at 5 different clients, all who appear to have a short frenulum, based on what I see. But what we're concerned about is functionality. Is the frenulum capable of enabling proper range of motion for bolus manipulation, for chewing, for safe swallowing? Because as you know, infants can also be assessed for having these procedures. And in my practice, what I've always looked at is functionality.
Yes.
So that's the
And
takeaway.
thank you. And I think that's what's lost. I think
Mhm.
big picture, we all want a quick fix because
Mhm.
it's easier. Trust me,
Mhm.
if there was a pill that I could take that had 0 side effects and I just magically woke up tomorrow about 10 pounds like toner, leaner, firmer, I'd give it serious consideration. Quick fix. But that's not the case.
Right.
So, yes. Yes. Okay. All right. So, what is an orofacial myofunctional disorder? And
Okay.
then what is an orofacial myologist? So
Okay.
like,
Okay.
because like that's confusing terminology.
That's a 2-part question. So
Yeah.
first, I'll address the definition of an orofacial myofunctional disorder. I will say that the terminology referring to this type of disorder can vary depending on where you read about this type of disorder. Um,
Okay. What do you mean?
for,
Where do you read? Like
for
within like
if you were to
SLP
Google,
literature?
yes, SLP literature, orthodontic and dental profession literature. If you were to do a Google search, depending on how long ago the information was published, you'll also see some differences. But some possible terms that refer to the same thing are simply and when I say simply, not saying that the disorder is simple, but without the orofacial label, myofunctional disorders. I don't know if you've ever heard just myofunctional disorders apart from the word orofacial, but
Yes.
that's referring to the same thing. You may have seen or heard oral muscle imbalance dysfunction.
No.
Okay, well, that's another term, and maybe some of the older literature. And then I'm certain you have heard of tongue thrust.
This I'm familiar with.
Okay, so essentially, what happens with tongue thrust, it is um, a type of skill that falls within the larger umbrella of, or not skill, a type of disorder that falls within the larger umbrella of oral facial myofunctional disorders. So some people use them synonymously. In
Okay.
other words, they're saying tongue thrust within itself refers to oral facial myofunctional disorders. But because oral facial myofunctional disorders is a broader set of um, possible disorders, tongue thrust is only one part of that.
Okay.
And I'll elaborate a bit. But if you want to think about the morphology of the words, oro refers to the mouth, facial refers to the face, myo refers to muscles, and functional refers to how things work. So, so essentially, any type of orofacial myofunctional disorder could potentially impede or interfere with the normal growth and development of the oral muscles, as well as the bones of the face and the mouth. So any disruption of any of those features could potentially be classified as an oral facial myofunctional disorder. So think of how we use the muscles for chewing, how we use the muscles for eating, even for breathing, and obviously for talking and swallowing. So the takeaway is that it's a broad label that refers to a lot of different potential problems. And the way to figure out what features need to be addressed or what impairments need to be addressed would be to engage the client in evaluation procedures to investigate all of those things.
Okay. So I went to a class at ASHA 2 years ago.
Mm-hmm,
We were at LA. It was
mm-hmm,
LA. So yeah. Linda D'Offrino. Oh my God, I'm butchering it. Linda D. She's got purple hair and gray hair, and she's like a powerhouse. It was my first class, but it was just a super brief overview, and that's where I first got curious about it. And she was talking about how they even have different ICD-10 codes.
mm-hmm. They
Are
do.
there different CPT codes as well, or is it the same CPT codes
It's
that SLPs use?
it's the same CPT code, but the different there could be different ICD-10s depending on what you're addressing. For example, think about before you say sparked an interest in this area. If you were to engage a client in an evaluation or therapy for anything within your scope, you would have one ICD-10 for whatever you identified with language, or a different
Uh-huh.
one that you identified for speech sounds, or a different one that you identified for dysphagia. It's no different um, than that. Essentially, not every client, for example, is going to have a tongue thrust, but
Mhm.
there could be some other things that fall under the range of skills that could be impaired that you identify an ICD-10 for that's fitting,
Okay. I
or
just thought
you
that was really
assign.
yeah,
Mhm.
I thought that was cool because I didn't even think of it as I just assumed because they're an SLP that wouldn't have even popped on my radar that there's a whole different ICD-10 code for this
Mhm.
until she showed them and I was like, "What?" And then I was like super curious cuz it made me wonder like could you have like a ICD-10 orofacial myofunctional code as well as like an oropharyngeal dysphagia
Yes,
ICD code? You
yes,
can?
yes. And unfortunately, I don't have immediate access to a medical software program that I can literally tell you what those are. But when you go to the certification courses, one part of the training does involve sharing that kind of information so that when the providers leave, they know what kinds of codes to bill under. Um,
That's brilliant.
mm,
That's those okay, folks, why am I chasing this? Because those are the details that like you wouldn't have thought would even fall within the wheelhouse of speech pathologists, that there's like this whole separate branch of ICD-10 codes. But what I do remember when she spoke was that you can't use an orofacial myofunctional ICD-10 code unless you were trained in it. And I was like, okay, that I can respect, because otherwise I wouldn't have known how to code that.
right,
So
right.
like,
And that
not
again
gonna do it.
may be one of the reasons that that information is shared within a certification course as
Yeah.
opposed to it being public domain information.
Okay. Okay, so then what is okay, so we know what an orofacial myofunctional disorder, we have the anatomical breakdown. But what is an orofacial is it's orofacial myologist or a facial
Okay. That is essentially a therapist or a clinician who has received the training to address that kind of impairment or those kinds of impairments.
So what
Essentially,
is the right word?
okay,
Orof
well, it's orofacial myologist.
orofacial oh, I didn't butcher it too bad. Okay, cool.
And I'll just say that I'll give you a little bit of background of how those terms, or why we use those terms. I won't say how they arose, but why we use them. They're essentially two credentials that I'm aware of presently that signify that a person has received advanced training in evidence based practices to render services for these types of disorders. The,
Mhm.
the first is issued by the International Association of Orofacial Myology, and that credential is the certified orofacial myologist. So you'll see individuals that have COM after their name.
Yes, I've seen that, and
Mhm.
this is one that gave me pause, the conversation that we opened with, okay, but you have a QOM.
Right, and that's through a different organization, which, by the way, I'm actually in the process of studying to receive or to pursue my COM. I won't say receive because pursuit doesn't automatically qualify for receipt, but
Yeah.
I'm completing the training, and well, I've already completed the training, but the studying for the exam and everything that's required for the COM. The one that I already have is the qualified orofacial myologist, and that one is offered through their site is the orofacialmyology.com site. It's it's
Hang on, orofacial
myology.com.
myology. Okay, I'm doing the Google, can you tell? Okay, I apparently don't know how to spell. Alright, I
Oro,
pulled it
it's all. I think the web link would be all the words connected. So oral.
Yes, okay, I found it.
Okay.
Okay, so one turns into the other. Is that kind of like the CLC versus the IBCLC? Like certified lactation is like a 1 week intensive course and a board exam. The international board certified lactation
Well,
certificate is that plus 1,500 hours of practicums.
no, one doesn't turn into the other. What happens is you can, as a practitioner, once you complete the 28-hour certification track course, you can pursue one or the other or both. They're
Okay.
they're both again engaged in evidence-based evaluation and treatment practices for oral facial myofunctional disorders. They're just basically two different organizations that offer the credentials that would enable a person to call themselves an orofacial myologist,
Okay.
if that makes sense.
Yes. Oh, the one that you just did, the orofacialmyology.com, is that Susan Holtzman or Sandra Holtzman?
Sandra, yes.
I have met her a couple times. She is a passionate little lady. She ain't big as a minute, and she is just a powerhouse.
She's fabulous.
Yes. Oh my gosh. Okay. Yes. Okay. All right. So I really like her. Y'all, Holtzman is spelled, hold on, Holtzman. And if memory serves correct, she's out of Florida. I think
Yes.
she's out of Florida. Yeah.
And I think she has some roots in North Carolina as well, but most of the courses or the nearest courses may be in Florida. I want to say, though, just in terms of clarifying, you can go to the certification course that her team offers, and that serves as the coursework that would enable you to pursue that International Association of Orofacial Myology's COM as well. So going to the Holtzman course or her team's course would lead to will qualify you for sitting for the QOM. However, you can then pursue the COM without having to go back for more coursework. There's just a different exam and other protocols that are a little different because there's a different organization that offers a different credential.
Gotcha. Okay. And I also saw the price tag on them, and now I remembered why it's on the to-do list. Because until both children are in full-time school and not preschool, that's not happening right now. Go team. Okay. So
I want to say something as well, though, and obviously I'm by all means encouraging and endorsing certifications and qualifications because we want to ensure that people who are rendering services are aware of best practices and following the evidence. However, I will say that having been a speech language pathologist for going into my 26th year now,
there still don't look like it.
Well, thank you. You're so kind. There are cases where individuals have had myofunctional disorders, and ASHA certified clinicians have been treating myofunctional disorders for years. So it's not, I don't want to give the impression that you have to have these credentials to do an effective job. Again, we're all ethically bound to standards of rendering the best care. So the research is out there. What may be a little more challenging for someone who has not attended one of these courses is perhaps figuring out, accessing the research and ensuring that you're actually following it or interpreting it because you're not within a body of individuals who sort of started that process for you. But again, people have been treating these disorders for years without certification credentials.
Yeah. Part of me wonders if they've been treating it, not recognizing what it was.
Right. And that's possible.
Yeah.
That's possible. But if you go, another source of information is, the ASHA website, the American Speech-Language Hearing Association. They actually refer you in some of their links to these other organizations for additional information. But, the ASHA website is certainly a place to get started. And in some cases, it could be that, necessity requires you to start something with a patient before you can get to a certification course. So that's another benefit, again, of just accessing the information and literature that are out there and at least attempting to your best ability, employ the evidence.
Yeah. I'm just wondering how many kids I've misdiagnosed. Sorry, that was a big long pause. Okay. All right. So then what causes, all right. So I have a theory and tell me if my theory is wrong. So what causes orofacial myofunctional disorders? But I feel like a lot of it is underlying aerodigestive or aerodynamic issues that because I feel like I see that all the time, and which is why we send our favorite ENT.
Yes.
And I feel like it's the Grand Canyon, like the wind blowing through the tunnel, and it causes one thing that leads to another thing, that it's not just one factor, but it's multifactorial.
And
Am
you're
I wrong?
no, you're as the saying goes, you've hit the nail on the head. Think of it. I want to back up a little though. If you think about an infant's development, when babies are taking a bottle or nipple, it's a normal primitive pattern per se that they exhibit the anterior to posterior tongue movement to to feed because
To express from the nipple. They're
right.
yeah, they're
Mhm.
quote unquote stripping the nipple.
Right.
That's how my
Yep.
lactation person taught me. I'll
Right.
never unhear that.
And because of the dimensions of the oral cavity, honestly, their tongue is limited in terms of the range of motion that it has. Um, everything's small, it's compact, and it's again anterior to posterior. Really is about the range of movement that they have. What should happen though, as their oral cavity expands, as uh, their mouth and head grow, you should start to see other patterns of movement. So
Mhm.
it has been hypothesized that some individuals just retain the anterior to posterior tongue movement longer than they should in development. And, if that isn't corrected, obviously an orofacial myofunctional disorder could arise. However, relating to what you are saying, if there is something that perhaps impedes movement, even when size is larger, for example, enlarged tonsils could restrict the space available for the base of the tongue to rest toward the pharynx, and therefore that child ends up having a relatively anterior resting posture of the tongue, literally because there's no
They
space.
can't get it back.
Right. Hmm.
That's yes, that Bear had giant whopping tonsils and he
Hmm.
fronted everything. He did that with his speech. That's why everything was a tootsie, because he couldn't get his tongue back because his
Hmm.
tonsils were like hockey pucks back there.
Hmm.
Yeah.
And another consideration is that, even if the tonsils don't appear to be large, we can't see the adenoid. And it's very possible that some of the space back there is being taken up by the adenoids that we can't see.
Um, Garner said when they laid, and y'all folks, I think I might have said this once or twice before in a prior episode, but when Garner did Bear's surgery, he said, yeah, they were pretty big when you did like an oral mech exam, right? But they weren't ostentatiously enlarged.
Hmm.
But when he laid down,
Hmm.
they almost completely occluded his airway from an AP perspective.
Yes. Hmm.
And that honestly, because I am mom, I couldn't think about that from a clinical perspective. But
Hmm.
then I was like, well, that would explain why we had such severe obstructive sleep apnea scores,
Yes.
because and at the time they didn't do his adenoids at surgeries. I mean, they did subsequently also do his adenoids.
Hmm.
But yeah, but you have to remember anatomy
Yes.
changes as the kid moves.
Yes. That's a good
Yep.
point. Exactly. And then also, I'll think of this as maybe a need for efficiency. If you see a child who is mouth breathing and who does have that anterior placement, perhaps they're doing that to open the airway because, as you
Hmm.
said, other variables could be occluding the airway or reducing the um, function of the airway. And they have to figure out a way to get more air in. And
Hmm.
so, I mean, like you said, they're related factors. So,
Yeah. No, this is hypertrophy of adenoid tissue. I've seen, I have a kid. You didn't get this one. Folks, a lot of times I get the tiny humans to start with, and then I'm like, okay, you don't need me anymore. You need Dr. Angela. And then like they exit the world of early intervention, and I'm like, Dr. Angela, fix the tiny human. But like, I have one little girl that, her adenoids were so enlarged, they were pulling her UES open through negative pressure and pulling up her GERD contents, thereby exacerbating her laryngomalacia at baseline.
Wow.
And I will like, oh, that's a new word. But like ever since then, whenever I hear like an audible snort when they're like sitting upright and I hear the same respiration patterns that I heard in that kid, I'm all like, so are you two tugging on your UES? And like I said that one time in front of a parent, and they were like, what did you just say? And I was like, I'm so sorry. Let me translate out of my really weird brain. Oh, yeah. Okay. All right. So airway issues can cause orofacial myofunctional. Just what about neurologic damage?
Yes. Absolutely.
Okay.
Because again, if you think back to I always say, if you're in doubt, refer to the morphology of the word. Myo is muscle, function is how it works. And so if there's neurologic injury that impedes muscle function, absolutely there could be some problems with these skills.
Okay. All right. So then tongue thrusting, you touched on it earlier, but is that the same thing as?
Well, it's related, but not entirely the same. If you imagine the individual that we just described in terms of them not having space for the tongue to properly rest in the mouth, what they could, because of all of these things that we talked about that might be influential to this occurring, they could essentially maintain their tongue in a more forward, habitual resting posture. And then that could carry over into what they're doing when they are chewing and swallowing food. And so what happens there is essentially, again, in addition to there being an anterior resting posture, when they swallow, they protrude the tongue or push the tongue forward, whether it's liquids, whether it's solids. And over time, that alters the entire shape of the oral cavity. So that,
Their teeth buck forward. They get
yeah,
like, I mean, I don't want to be mean and say the horse face, but like those prolonged facial features.
yes.
That's what I think of.
And it could also obviously affect their occlusion. You see various malocclusions that are,
Sorry. The way the teeth bite together, malocclusions.
yeah.
Yeah.
So an open bite, for example, sometimes some of the kids, and I say kids, but if these disorders are not corrected in childhood, they can persist into adulthood. So although we try to identify them when individuals are young, it's very possible that a clinician will see adults on their caseload that have these difficulties because of problems that arose when they were younger but were never addressed.
Go ahead.
And I was going to say another scenario of adults is that some individuals have gone for orthodontic treatment that was probably contributed to by an undiagnosed orofacial myofunctional disorder. So, what do you think happens when the orthodontic treatment is over? The braces are taken off. What do you think could happen?
Their teeth go right back.
Yes. And so I've actually seen individuals in therapy that have enrolled after what we call orthodontic relapse because there was no myofunctional therapy that preceded or occurred in conjunction with the orthodontic treatment. And so that's another situation where adults could receive this type of therapy. So my point is, it's not always children. I again say children a lot because we identify them or try to identify them early, but this is not exclusive to children.
See, Matthew has it, my special needs brother-in-law. Like, you can tell he's still doing tongue thrusting, but they can't remove his adenoids, and we know he has hypertrophy of his adenoid tissues because he doesn't do well under anesthesia. So it's kind of like it's functional. He's 42 years old, and we're not gonna, oh my gosh, he's 43. Shame on me. So, like, we're just gonna, like, let it ride. But, like, I was kind of wonder what if, like, what if we'd gotten him to a different therapist earlier? Like,
Right.
The second opinion factor, you know what I mean? Okay, so and I'm thinking of a little girl that I saw like 2 summers ago, and I was like, get him to Garner, and I got the kiddo to Garner, and like as soon as I got the kiddo to Garner and they did the sleep study and the adenoidectomy, it dramatically improved. But she was tongue thrusting at like 10, but she had all of these other concomitant etiologies such as like autism spectrum disorders. And it was like, what is the most ideal outcome to help her when given those comorbidities? We couldn't do as much as we wanted. So like we did that couple of diet change recommendations for like cut presentations and then just left it. But I mean, that was what was good for her stars, but you're still making me wonder.
That scenario or situation you just described reminded me of something I want to say. If a client is enrolled in this type of therapy, there are expectations in terms of the client's ability to follow instructions, to carry out
Participate.
exercises, and also to follow through with home program activities, because changing these skills will not occur only or as a result of only doing them when they're in the therapist's presence. They're literally having to take information home and integrate it into their environment. And so, when you talk about candidacy for certain types of interventions, that's something that every clinician will need to assess. Not every person who has this type of disorder is particularly going to be a candidate for the types of training that might be needed to essentially retrain the oral mechanism, orofacial myofunctional skills. But you may have to implement some other measures, as you said, changing the diet, doing parent training, doing whatever it takes for them to have the safest type of swallow or the most functional feeding skills, despite the presence of any difficulties that are there.
Yes.
Does that make sense?
Yes. And I didn't know that. So that's good to know. I didn't. Yeah. Huh. Okay.
I also thought of one other thing I wanted to mention that stems or relates to the question you asked earlier about the frenectomy.
Yeah.
I saw a little boy who, he had all signs and symptoms of a myofunctional disorder, and clearly there were some airway issues, but he also had a visually and a functionally restricted frenulum. And so I referred to the ENT for consult to have his airway assessed, because obviously that's not in our scope. So having the airway assessed, and then also seeing about his candidacy for having a frenectomy. It turns out that he was a little boy who visually, when you looked into his mouth, you could not, his tonsils looked fine. But when they did a scope, they identified huge adenoids. And the report that I got from the ENT was that because of his airway being so compromised because of the size of the adenoids, a frenectomy in that child would have placed him at risk of an even further compromised airway. In other words, the fact that he had a restricted frenulum was protecting his airway. And if someone hadn't assessed the airway and just jumped into, but based on the visual appearance of the frenulum, to release it, it could have been detrimental to his health.
Yes, Thank you for saying that. Our sweet friend Leslie down at MUSC had that happen.
Hmm.
2 kids twice within, I think it was like a really short period, like maybe even 8 weeks. And 2 kids went to a dentist and had a frenectomy without having an airway evaluation done first.
Hmm.
Both kids ended up having to have trachs.
Oh, wow. Oh,
Yeah,
wow.
it was, yeah, and they were like, there was so much other stuff going on with the airway,
Hmm.
and it was their lingual frenulum was anchoring the tongue in place, and the second they let that sucker loose, it completely occluded the airway, and what they were able to move air through had previously been stopped. And
Wow.
I just and y'all, I know we're talking about extremes, but do go back to that one research article that's now completely eclipsed my mind that we referenced, where they said that there were cases that where it was absolutely necessary.
Right.
Then there's more cases where I think it was like 66% that it was not, 15% where it was counterindicated,
Hmm.
and then like whatever the percent was, like 10 or 15 where it was.
Right.
So yeah, but I mean, again, yes, but see, that's why we have a holistic team,
Yes.
because when you utilize interprofessional practice, which we are like, that is paramount to our profession. Don't be a silo SLP, utilize interprofessional practice, then you find those things out. Oh my
Right.
stars. Okay, yes. Okay, so then that gets me to, all right. So I have so many. Oh my God, you're coming back for part 2, right? Because like we're
Sure.
not going to cover all this in an hour.
If you will have me, I'll be delighted to return.
Yes. Okay, folks, what y'all don't know is behind the scenes, I always say to people, give me like maybe 3 or 4 questions for me to ask you so that we can like, build it. And Dr. Angela sent me 13. And I was like, not that she is too a type A SLP, but it's cool like that. And I was like, well, I'm not going to get all this in 1 hour because my ADD will kick in with all the squirrels. So I'm like, okay, so then, um, how does orofacial myofunctional disorders relate to oral? Are they the same as oral motor difficulties, or are those like 2 different things? I don't even like to use the term oral motor difficulties. I got to be honest. I am hesitant of that term even.
Well,
So,
and
hey,
here's the thing. I think it again refers to where you're reading about the literature. You've been in our field long enough to hear about, the controversy of implementing oral motor exercises to uh,
non-speech oral motor
right,
exercises, just
right.
say no. Yeah.
So, they're not intended to be the same because here we're with the oral facial myofunctional disorders. We've identified via scientific investigation that there are authentic difficulties with facial musculature, um, perhaps skeletal growth, just various aspects of the client's anatomy and function. Whereas in a broader sense, oral motor could refer to just range of motion exercises or tasks without linking them to known organic variables. So,
Okay, so translation,
mhm.
because Dr. Angela's used to teaching all the younger ladies, and also I know like they love you. Every student I've ever had, they're like,
Aw,
"Oh my God, we love her. She's a goddess." And I'm like, "I know,
aw,
right?" So like, but like I am not as PC because I don't torture the tiny humans and masses. But the non-speech oral motor exercises, stick your tongue out, touch your nose, stick your
yes,
tongue out, move it to the right 18 times, and then move
right,
it to the left 18 times. Neuroplasticity, we don't learn that way.
right.
And
And
then,
and
yeah.
those things that you just described are typically what are meant when the term oral motor exercises is used, when that term is
Mhm.
used, those types of things. And, by definition, those could be anything that they aren't particularly linked to a function, but they're supposed to influence development of speech. So they could be, as you said, sticking out the tongue, elevating, rounding the lips, holding air in the cheeks. but there isn't a known.
Blowing through straws. That's one
Yes.
of my favorites.
Mhm.
Doing the straw therapy, because I got asked one time,
Right.
well, don't you do the straw therapy and blowing through whistles? And I was like, no, I do not.
Now, the thing is, they're purported to influence tongue movements of the tongue and the lips, um, to alter strength, to improve muscle tone, etc. But there isn't evidence to say that.
Mm-hmm. 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 Aaron and I have covered this in copious volumes because her
Mhm.
and I feel really strongly about that.
Mhm.
Okay, so then if you're going in and doing your eval, and you sent a PDF with this, is that can I like link that somehow or like add that as a picture on Instagram?
Well,
Would that be
that's not really an eval form, but that actually is out there in the public domain. The reason I
awesome?
shared it with you is because it has literally almost everything that you might see if you suspect a person of having an orofacial myofunctional disorder. It's all together in one handy sheet. But that was
Those are the signs and symptoms you mean?
right. Hmm.
Yes.
But
Okay.
and the thing is that not everything on there is particularly going to be going on with every client that you see. Like, in other words, a client may only exhibit one or two of those characteristics, but they still would be considered to have, or could be considered to have, an orofacial myofunctional disorder. You might have one client with two of those things. You might have another client with seven of those things. You might have a different client with 20 of those things. But
Oh, good Lord.
they're just
Sounds like
sort
that
of,
kid needs a lot.
think of it as a checklist of things to look for that would put you on high alert that an orofacial myofunctional disorder could be present. And it's not my checklist. It actually was downloaded from the AMOT, which is, I think, the Academy of Orofacial and Myofunctional Therapists. Now, to my knowledge, there isn't a credential that comes from that organization. I don't want to misspeak, but I'm not aware of any other credential than the ones I mentioned to you earlier. But I definitely like this checklist because it is pretty comprehensive.
Oh yeah, I found it.
Okay.
Okay. Academy of Orofacial Myofunctional Therapy.
Mhm.
Okay. And it's right on there.
Okay.
Okay. Okay. Screening tools and booklets.
Mhm.
Yes. Intro course. Yes. Okay. So they have a ton of stuff too. Oh, this is fantastic.
Mhm.
Also, they have a whole lot of courses that are live. I feel like those live courses are probably not happening right now, given the state of things.
Right.
So, like,
Right.
yeah, just putting that thought out there because I don't feel like you can social distance while doing an oral mech exam.
Oh, you absolutely cannot. The course that I went to was very intensive. Again, it was 28 hours, and
Was it like over 5 days?
it was over 3 days, but we were sort of
Um,
in quarantine before we realized we had to be. But we were literally in a room from about 7 in the morning until about 6 in the afternoon for 3 consecutive days.
did
So
good God, did you have homework afterwards?
we would just have to do practical exams in the class. Like, we would get in groups or pairs and basically run through the procedures with the instructors walking around and giving us corrective feedback. So, and then we took tests while we were there before
I
like at the end of the day, say between 4 and 6 or 5 and 6 is when we would take the written part. But all the practical things were done during the
Yeah, my brain just hurt by your description. Thank
day.
you.
But it was so helpful.
Yeah, but I love hands-on classes like that. Um, okay, all right. I'm looking at our time. Okay, so we have a source for signs and symptoms. So what are the if you could give us like the top 5 signs and symptoms, what are the things that you see the most that you think, okay, well, that's a red flag?
Well, maybe one of the more obvious is breathing through the mouth um, versus breathing through the nose. A person should not habitually mouth breathe when they're healthy. Now, a person who has a cold or, an upper respiratory infection temporarily may mouth breathe, again, just to get more air in. But I'm sure you've seen children who do it all the time, like all
Yep.
seasons, and it could
Yep.
be allergy related. So, in that case, there's still potential for the airway to be compromised, and that's why they're doing that. So that's a red flag. Um, Having a habitual open mouth, like when they're resting, just
Mm-hmm.
looking at them, and their lips should be sealed and they should be breathing through their nose if everything is working as it should.
Mm-hmm.
Okay, then obviously you might observe when they're drinking or eating food. We talked about that tongue thrust behavior where
Mm-hmm.
the tongue moves anteriorly. Sometimes they will actually protrude the tongue to greet a cup when they're drinking, or they push material out of the mouth when they're chewing. I've seen individuals actually lose material from the mouth when
Okay. Hey, hold on one second. I just want to, folks, we're not talking about emergent feeders here.
right,
Like if you're 6 to 9 months old developmentally and you're doing that, like
right,
I still chuck that up too. That's the normal process of learning to eat.
yes,
But like when you're older, like for me, when you're developmentally between 10 and 12 months, I start having concerns that we're seeing what I would label as an unintegrated tongue protrusion reflex, which has turned into tongue thrusting,
right.
which you weren't kidding. I've got to do this. I've got
Hmm.
bloody hell, but it's like all the monies. So we're going to have to like start saving pennies up, Angela. This is
Hmm.
really cool. Okay. Yes. All right. But yes. So just to clarify, it's not the emergent eaters. Okay.
Right.
So
Some
I'm sorry, squirreled.
some other things that you want to be vigilant about are what I'll call oral habits. So a person who has maybe retained usage of a pacifier for an extended period, um, sucking on their finger or thumb. I've actually even seen children who suck their tongue. Like it's not apparent um, maybe immediately, but if you spend a few minutes with them, you could actually observe like the lip movements that indicate that there's sucking going on behind closed lips.
Uh
So,
huh.
nail biting, chewing on.
Wait, nail biting?
Hmm. Yeah, because what happens is if a person has exhibited long-term nail biting, there's something in the front of the mouth that's altering where the habitual placement of the tongue is. And over time, that could contribute to what they're basically they develop a different tongue resting posture. So it could actually impact oral facial myofunctional skills.
That's crazy. I've
Hmm.
had a couple kids that sucked somehow or another. They would put their thumb on the side of their jaw, almost as
Hmm.
if they're like stabilizing it, and
Hmm.
then like suck their index finger and their middle fingers to the point that like if that had been me and my fingers were back that far, I would have upchucked. Like there would be a significant amount of emesis that just graced the floor. But they would suck in that way, and I've seen it a couple of times.
Hmm.
Um, and it was and those front teeth, because I mean, to get your hand in there, I mean, they're going almost all the way to their knuckles. Like
Right,
those front teeth would be so
right.
bowed out.
And
Yeah.
that's the other thing I was going to mention. Just again, malocclusions, and one of the most apparent is that open bite. It literally looks like something has been um, positioned in between the upper and lower teeth for some period of time, such that there's an opening. Like it
Mhm.
literally looks like there's just enough space for the tip of the tongue or
Mhm.
a digit, one of the fingers. But some individuals who exhibit I'm sorry, some individuals can exhibit malocclusions that aren't an open bite. So an an
Mhm.
open sorry an overbite, an overjet, as you mentioned, you called it, I think, buck teeth,
Mhm.
even a cross bite. I've actually seen clients who have a what I'll call a bilateral open bite because they're chewing on the sides of the tongue. I mean, so there are all kinds of things that could be.
Wait, I'm trying to get a picture for a bilateral open bite. So like their molars don't reach down on the sides
Yes.
because they're Oh,
Mhm.
how are you going to chew your food? I
Well,
bet they're anterior chewers then on food.
probably. Yep. And again, that, we didn't talk in this conversation about the evaluation procedure. So if you do have me come back, maybe we could talk some about it then. But the evaluation that you complete would actually have you investigate, in addition to a very intensive oral mechanism exam, you would investigate how they are chewing and swallowing with various food textures. And then perhaps that would be discovered, in that part of an assessment. And
So then let's do that one next time. Let's do how you do an eval and what treatment looks like.
okay, that sounds good.
Yeah, for the next one
Okay.
because
But
there's so many signs and symptoms.
yeah, exactly. And so I think you said earlier that there are probably a number of clients that you've worked with who could have some underlying orofacial myofunctional difficulties that haven't been identified. And that's why you're seeing so much of what you do in the feeding and swallowing therapy.
Mhm. Okay, so who do you refer to? Like as an orofacial myologist,
Hmm.
like when you see these kiddos, who are your top collaborative professionals to treat? Because a lot of what you're describing sounds like the underlying issues are
Hmm.
outside of the wheelhouse of the SLP.
Well,
So,
I actually, again, I'm because of COVID-19, I'm working out of the office, but at my regular office, I have a list of allergists and ENTs in the area, as well as a couple of dentists that I've
okay.
worked with, and one periodontist. And then there aren't, as far as other SLPs, there aren't many in our geographic region who have either the certified oral facial myologist credential or the qualified oral facial myologist credential. But that oralfacialmyology.com link that you pulled up earlier lists clinicians by geographic region. And so
Mhm.
if there were a concerned clinician, they could look at um, that website and find someone if, again, if they were wanting to refer to a specialist.
But I love that it's also encouraged to have interprofessional
Oh yeah,
practice.
it's all about IPE. This is not something that can be thoroughly and accurately completed by just an individual practitioner.
Okay, so can is it only SLPs that get their QOM or COM, or can other disciplines get that certification?
That's a good question because it's something I forgot to mention. Um, you don't have to be an SLP. You can be a registered dental hygienist. You could be a dentist. You could be an orthodontist. Um, I think for the Holtzman course that you mentioned um, earlier, when a person who is a professional from the dental community gets theirs, they still get the QOM, but I think there may be a signifier that indicates that the person has a dental background versus an SLP background. Again, I'm not looking at the site, so don't quote me on that, but I remember seeing that. So, but the point is they have still gone through the same training. It's just that the pre-course training is different because of the disciplines that in which that they chose to pursue. So
Oh, no, I love that. Okay. Okay, so I'm gonna hold us there. Hold on one second. Um, and highlight where on our questions we did not get. Um, because you sent me 13. Oh my God, I love you so much.
and
Uh,
and after
uh,
this talk, I may have to send you some more.
that honey, this is so fascinating to me because you're finally connecting pieces that like we made it to question number 7. How about that on that you sent me?
Okay.
So we'll have to. Okay, all right. So then, yeah, Lord Almighty, I got so many more. So before we switch to questions, is there anything else you want to get in on just describing what it is and what it's not?
Well, I feel like I've talked a whole lot. I'm not sure that I want to add anymore, except, again, visit those links or those sites that we talked about, the ASHA website, the IAOM website, and the oralfacialmyology.com website, because I think looking at the information that's out there and then listening to this kind of discussion will help people to make some connections, because it's really a very broad field per se. It's specialized, but there's so many different components that need to be looked at. So that's why I say it's also broad.
Yeah. No, I get that. Okay. All right. So if someone has a question directly for you, would you be willing to share your email so that they could
Sure.
reach out to you?
Sure.
Okay.
It is. I'll spell it. It's C as in cat, L as in Larry, E as in Edward, O, D as in Daniel, A, N as in Nancy. So that's McLeod, A-N, at mailbox dot S as in Sam, C as in cat, dot edu. So McLeod, A-N, at mailbox dot sc dot edu.
Okay. Now I just want to know, because you're like just part of USC, because that's when I think of the people at USC, you're always part of that. Have you always been at USC?
No, I started there part-time. I think is probably 2002,
Okay.
teaching as an adjunct.
Uh-huh.
2002 or 2003. I became a full-time faculty member in 2007 as a clinical assistant professor. However, in my work prior to USC, I worked in a hospital, I worked in a rehab center, I worked in home health, I worked in a public school, I was a baby net early intervention therapist.
Yay!
I did a little Head Start. I'm trying to think. I'll just say this: probably I did skilled nursing facility. Yes, probably
Oh, I
every
can't.
facility or every setting that SLPs can work in.
Uh-huh.
I worked in, and just to clear or set the record straight, I didn't job job like hop from one job to the next. I didn't do that. What happened is I worked primarily in a rural community, so there
Uh-huh.
was always a shortage of SLPs, and so everyone knew everyone, and so if I were the hospital therapist, then the skilled nursing facility knew about me, and so the census at skilled nursing facilities was always small enough that I, could go in and see one or two patients and then still. Does that make sense? So in other words, it
Yeah.
wasn't like I, worked for 2 years there, this place, and then worked for a year another place, and then worked for another year. I was very stable with where I was, but it's just that the community
It's rural.
yeah.
Yeah, I grew up in the country. I was the only SLP at a rural hospital, and I did
Mhm.
inpatient in the morning and outpatient in the
Yeah.
afternoon, and covered 2 to 99.
Yeah.
Well, actually, the oldest was 103, and he was very spry. That's the best adjective for him, was spry. He let me drive his sports car, and then like a couple of weeks later, they took his keys. But like
Oh,
that
wow.
was fun.
Mhm.
Yeah, small town living, baby.
Yes. Mhm.
Oh, all right, hold on. I love you. Hold on one second and let me switch us over to questions, okay?
Okay.
Okay. Feeding Matters guides system-wide changes by uniting caregivers, professionals, and community partners under the Pediatric Feeding Disorder Alliance. So what is this alliance? The Alliance is an open access collaborative community focused on achieving strategic goals within 3 focus areas: education, advocacy, and research. So who is the Alliance? It's you. The Alliance is open to any person passionate about improving care for children with a pediatric feeding disorder. To date, 187 professionals, caregivers, and partners have joined the Alliance. You can join today by visiting the Feeding Matters website at www.feedingmatters.org. Click on PFD Alliance tab and sign up today. Change is possible when we work together. That's a wrap, folks. Once again, thank you for listening to First Bite, fed, fun, and functional. I'm your humble but yet sassy host, Michelle Dawson. the All Things Peds SLP. This podcast is part of a course offered for continuing education through speechtherapypd.com. Please check out the website if you'd like to learn more about CEU opportunities for this episode, as well as the ones that are archived. And as always, remember, feed your mind, feed your soul, be kind, and feed those babies.